Myself Dr. Ramya, lecturer from the Department of Oral and Maxillofacial Surgery, Yenepoya Dental College. Today I am going to discuss on the topic of temporomandibular joint anatomy and dislocation. Before the end of this lecture, one should be able to tell about the anatomy of the temporomandibular joint, definition and of the dislocation and subluxation, clinical features of dislocation and management of dislocation. Coming to temporomandibular joint anatomy, the TMJ anatomy as such is nothing but the temporomandibular joint. It is the articulation between the squamous part of the temporal bone, which you can see here, and the head of the mandibular condyle. As the name suggests, it consists of two articulating surfaces. One is the upper articulating surface and the lower articulating surface. The upper articulating surface is formed by the mandibular fossa, which is a part of the squamous part of the temporal bone, and the articular eminence, whereas the lower articulating surface is formed by that of the condylar head. This temporomandibular joint is also called as synovial joint or diarthroidal joint, meaning a synovial joint is nothing but it is a joint between the two articulating surfaces, means the two bones which are connected together by means of a fibrous capsule, and within the fibrous capsule there is a synovial fluid, and this synovial joints are freely movable joints. This temporomandibular joint is also called as a complex joint, meaning it is a bilateral joint and the two joints has to function in unison to perform a mandibular movements. In between the two articulating surfaces, that is the upper articulating surface and the lower articulating surface, is the articular disc. This articular disc, it is a fibrocartilaginous tissue and it is avascular and it is non-innervated. The superior surface of the articular disc, as you can see in the picture, is concavo-convex, whereas the inferior surface is concave. This articular disc divides the joint cavity into two compartments, that is a superior joint cavity and the inferior joint cavity over here and the superior joint cavity over here. And this articular disc is divided into three zones. First one, this is the anterior zone, the intermediate zone and the posterior zone. Behind the posterior zone is the retrodiscal tissue, or it is also called as posterior bilaminar zone, and it is in contrast to the articular disc, this posterior bilaminar zone consists of loose areolar tissue and it is highly vascular and it is innervated. As I had already mentioned that the temporomandibular joint is a synovial joint. This is filled with the synovial fluid. If you see in the upper joint cavity, the synovial fluid volume is about 1.2 ml, and whereas in the inferior joint cavity it is about 0.9 ml. The function of the synovial fluid is mainly lubrication of the joint during mandibular movements and also metabolic exchange, and also acts as a shock absorber. Next, coming to the ligaments. Ligaments are nothing but the collagenous connective tissue fibers of particular lengths. Usually the ligaments, they do not stretch but act as a restraining devices to limit the extreme border movements of mandible. If in case extensive forces are applied to any ligament, whether suddenly or over a prolonged period of time, the ligaments can get elongated, compromising the function of the ligament, thereby altering the joint function. The ligaments can be categorized as follows. There are three major ligaments and two accessory ligaments. The three major ligaments are collateral ligaments, capsular ligament, temporomandibular joint or the lateral ligament, and the accessory ligament, which are sphenomandibular ligaments and stylomandibular ligaments. The collateral or the discal ligament attaches to the medial and the lateral borders, as you can see here in the picture, attaches to the medial as well as the lateral borders of the articular disc to the pole of the condyle. The main purpose of this ligament is to attach the articular disc on the medial aspect and the lateral aspect to that of the condyle. The main function of this collateral ligament is to restrict the movement of the disc away from the condyle, and it is also responsible for the hinge movement of the joint. Next comes the capsular ligament. The temporomandibular joint as such is surrounded and encompassed by this capsular ligament. The function of this capsular ligament is to resist any medial, lateral or the inferior forces that tend to separate the condyle from the temporomandibular fossa or from the glenoid fossa, and the other function of the capsular ligament is to retain the synovial fluid. The other next major ligament is the lateral or the temporomandibular joint ligament. The lateral aspect of the capsular ligament is mainly reinforced by a strong tight fibers that make up this lateral ligament or temporomandibular joint ligament. The main function of this ligament is to prevent extreme posterior movement of the condyle and the disc, and also the anterior excursion of the jaw. And this, because of this prevention of movements in the posterior and as well as the anterior extreme movements, this is called as check ligament. The accessory ligaments, that is the stylomandibular and the splenomandibular ligaments, does not play a significant role. Next comes the mandibular movements. The mandibular, when the mandible moves, there are two main movements which is happening in the joint space. First movement is the hinge movement, and the second movement is the sliding movement or the translatory movement. The hinge movement, when one opens the mouth, the hinge movement that happens is for the first 10 mm. The mouth opening, for the first 10 mm of the mouth opening, the hinge movement happens, that is, which happens in the lower border, whereas in the upper joint cavity, that happens in the as and when the mandible is sliding along with the articular disc, and it passes along the posterior superior slope. As you can see here, it passes along the posterior superior slope, and then it ends when on full opening, and it ends inferior to that of the articular eminence. This movement is called as translation. That is why it is called as a gangliomo-arthroidal joint. Ganglimus meaning hinging joint and diarthroidal meaning sliding joint. The hinging movement happens in that of the upper joint cavity, whereas the sliding or the translation movement happens in the inferior joint cavity. Coming to the nerve supply, main nerve supply is the auriculotemporal nerve, mesenteric nerve and the posterior deep temporal nerve, and the blood supply is the superficial temporal branch of the external carotid artery, and the rich vascular supply is provided by the deep auricular and the posterior auricular and the mesenteric branches of the internal maxillary artery. Next, coming to dislocation. The dislocation as such is nothing but a hypermobility disorder of the TMJ. In general, the hypermobility disorders of TMJ present in two major forms. One is subluxation and the other one is dislocation. Subluxation as such is defined as the displacement of the condyle out of the glenoid fossa and anterosuperior to the articular eminence, which can be reduced by the patient. Whereas dislocation is similar to that of the displacement of the condyle, but which cannot be self-reduced. That is the major difference between the dislocation and subluxation. Subluxation can be self-reduced, whereas dislocation cannot be self-reduced. As you can see in the picture, what happens in case of dislocation or subluxation is the condyle tends to move out of this glenoid fossa and slide anteriorly to the articular eminence, anterosuperior to the articular eminence, and stays in front of the articular eminence. This is what is dislocation. In case when the patient is able to reduce it, it is called as subluxation. If the patient is not able to reduce, it is called as dislocation. There are various pathogenesis involved in the dislocation or subluxation. One can be either soft tissue changes or hard tissue changes. The soft tissue changes means there is some laxity of the capsules and the ligaments, which I had mentioned already, or the hard tissue changes meaning there can be some abnormality in the anatomy of the bone or in the eminence. There are certain predisposing factors which includes overextension injuries and seizure disorders while opening the mouth open, wide opening of the mouth, and while vomiting or yawning could lead to dislocation. Other extrinsic factors such as trauma or blow to the chin when the mouth is opened wide could also lead to dislocation, and manipulation of the jaw during intubation, endoscopy or tooth extractions when the patient is subjected to open the mouth wide for a long period of time could lead to dislocation. And other connective tissue disorders like Ehlers-Danlos syndrome and Marfan syndrome could lead to laxity of the ligaments and the capsule surrounding the joint, which could lead to dislocation. And certain drugs are prone to induce dislocation such as phenothiazines and also the psychogenic drugs which are given to those patients, and also Parkinson's disease and tardive orofacial dyskinesia patients can have a tendency for habitual dislocation. There are different types of dislocation. First one is acute, and habitual dislocation is nothing but subluxation, and chronic recurrent dislocation which occurs more than once is called as, when the dislocation occurs more than once, it is called as chronic recurrent, and long standing or chronic protracted dislocation is nothing but when the dislocation is persisting for more than a month. The dislocation can be either unilateral or bilateral, and it can be anterior, posterior, lateral or superior, but the most common is anterior type of dislocation. Akinbami has classified the dislocation into 3 types. Type 1 is wherein the head of the condyle is directly below the tip of the eminence, and type 2 wherein the head of the condyle is in front of the tip of the eminence, and type 3 wherein the head of the condyle is up in the front of the base of the eminence. Now, there are certain symptoms which helps you to diagnose whether the patient had dislocation or not. First and foremost is inability of the patient to close the mouth. It varies accordingly to the unilateral and whether it is bilateral. Both the conditions will have inability to close the mouth, whereas in case of unilateral dislocation, there is a tendency that the mandible shifts to the opposite side. Next is there will be a preauricular depression of the skin, and the prominence of the condyle can be noted anterior to that of the articular eminence, and the patient will have an elongated face appearance, and there will be excessive salivation, and the muscles of mastication will be tense and spasmodic, and there will be severe pain in the temporomandibular joint area. This is the case of right side TMJ dislocation, wherein the patient jaw is deviated to the opposite side, and also in the below picture you can see that the patient is having an elongated face. It is a case of bilateral TMJ dislocation, and in the second picture you can see there is a preauricular depression, and once reduction you can see the difference between the face, how long and it has been reduced. Once after reduction the length of the face has been reduced. Next, coming to the management. It varies accordingly whether it is acute or chronic. The management will be varied. Treatment for acute dislocation is a manual reduction without anesthesia or manual reduction with local anesthesia and sedation, and reduction with the gag reflex or manual reduction under general anesthesia. There are certain reduction methods which has been followed, of which Nilatens or Hippocratic method is the most common technique which is usually followed. This is a method in which one has to place the molar, one has to place the thumb finger as shown in this figure on the occlusal aspect of the molars or on the buccal sulcus, and the remaining fingers has to be placed below the lower border of the mandible, and the movements are first you have to give a downward movement and then backward and then upward movements. This is how we will be reducing the dislocated condyle. First is placing the fingers on the occlusal aspect as shown in this figure, and then the lower part and the remaining fingers on the lower border of the mandible, and give a downward backward pressure and then an upward pressure, which basically follows along the natural eminence. Next is an Avang's method. In this method, a gag reflex is initiated. In alert individuals, what happens is that this reflex will relax the lateral pterygoid muscle through coordinated neuromuscular activities, and which in turn will reduce the dislocation in a natural way. Next method is a wrist pivot method, wherein the thumb is placed in the chin region as shown in this figure, and the other fingers are placed on the occlusal aspect in the anterior area. And in this method you have to give a upward movement in the thumb, and the other fingers will be with other fingers you have to give a concomitant inferior force with pivoting in the wrist, and this will help in reduction of the condyle in the proper position. And next is management of chronic recurrent dislocation or subluxation. Management options includes either non-surgical or surgical. Non-surgical, it can be either conservative or minimally invasive, and surgical, it includes arthroscopy and open surgical methods. Conservative methods includes physiotherapy, intermaxillary fixation, chains, chin strips, and then Barton's bandage. Physiotherapy including ultrasound or infrared therapy are advised mainly to reduce the pain, and isotonic and isometric exercises are advised mainly to strengthen the muscles in and around the TMJ. The intermaxillary fixation, the chin straps, and the Barton's bandage are advised for a minimum of 4 weeks, mainly to induce the fibrosis around the joint space, which will limit the dislocation. Next is minimally invasive management, wherein certain injections are given around the joint and inside the joint and around the joint, which will help in reduction of the dislocation. First is sclerotherapy, next is prolotherapy, autologous blood injections or PRP can be given, and then Botox injections. First and foremost is sclerotherapy. Sclerotherapy is nothing but is a technique in which certain sclerosing agents are injected around the in and around the pericapsular region. The older agents which have been used are sodium silate, sodium morphate, and sodium tetradecyl sulfate. Now recently cyclophosphamide, alcohol, tetracycline, ethanolamine oleate, iodine, and OK432 are also used. Basically this is given intra-articularly and also in the pericapsular region. This produces fibrosis around the joint, which limits the dislocation, and it can be repeated every 2 to 3 weeks till the fibrosis occurs. The main disadvantage of this technique is it produces fibrosis, but it is short-lived. Next comes the prolotherapy. It is also called as regenerative injection therapy, wherein the certain non-pharmacological solutions are injected into the pericapsular and the tendinous tissues to stimulate the regenerative potential. The drugs used are dextrose, psyllium seed oil, glycerin, and phenol, but the most commonly used one is 2 ml of 10 to 50% of dextrose is most commonly used. Next comes the autologous blood injections. It was initially described by Brackman in 1964. Basically, the intra-articular injections are aimed at initiating an intra or pericapsular inflammatory response. This inflammatory response in turn will create fibrosis and adhesions, which will prevent dislocation. Next is botulinum toxin injections. Type A botulinum toxin is used up to 25 to 50 units. The main muscle which is targeted here is the lateral pterygoid muscle. It can be given either intraorally or extraorally. In extraorally, it can be accessed percutaneously through the sigmoid notch beneath the zygomatic arch, whereas intraorally it gets injected transorally through the lateral pterygoid into the lateral pterygoid under EMG guidance. Next comes the surgical options. As I had already mentioned, the problem with the dislocation happens either because of some hard tissue deficiency and some hard tissue deficiency, both of which can be corrected. So accordingly, there are 4 main subheadings under which all these management options come. First one is capsule tightening method, which is called as under which is capsulorrhaphy. Next one is creation of mechanical obstruction, and certain procedures was given by Lindemann, Mayer, Daughtry, and Finlay. And creation of new muscular balance, which is scarification of the temporalis muscle and lateral pterygoid myotomy, and removal of the mechanical obstacle, which is high condylectomy and eminectomy. First is capsulorrhaphy or capsular plication. As I had already mentioned, this is a capsule tightening procedure. Basically, the capsule is laxity of the capsule happens. So, in order to basically tighten the capsule, what is done here is you are excising a portion of the lateral capsule and it is sutured together to increase the tightness, and thus it will restrain the condyle. Or another method is just putting a vertical incision on the capsule and overlapping it and suturing it. That also leads to tautness of the capsule, and thus it restrains the condyle. And next one is to increase the create a mechanical obstacle. First and foremost is glenotemporal osteotomy, which was proposed by Lindemann. What he suggested is that he performed an osteotomy on the eminence, as shown here. He performed an osteotomy and then fractured it down. So, fractured it down in front of the condylar head to prevent the forward movement. So, when the height of the eminence is increased, the condyle won't be able to glide and move along the articular eminence. This will prevent the dislocation. And Mayer, in addition to this, Lindemann suggested to place an graft in the osteomized area that will further help to increase the size and the height, which in turn will limit the condylar movement. Next one is Daughtry procedure. Daughtry procedure is where, which was advised by Daughtry, is a technique in which an oblique osteotomy is placed on the zygomatic arch in the front of the articular eminence, extending posterior superior to the anterior inferior direction. It extends from the posterior superior to the anterior inferior direction, as shown here. With gentle pressure, what happens is that with gentle pressure is given from the upward direction, it fractures at the zygomatico-temporal suture. A green stick fracture is created, so that segment will come below, means the segment is pushed downwards to create the obstruction for the condylar movement. As the segment is below here, the condyle which is present here won't be able to translate and go forward beyond this obstructed area. Next is Finlay's L-shaped mini plates. Finlay suggested using mini plates which has been anchored to the zygomatic process, that is projecting straight in front like this, so that it prevents the further translation of the condyle, so in order so that dislocation won't happen in further times. Next is creation of new muscular balance. First is temporalis scarification and lateral pterygoid myotomy. Temporalis scarification is nothing but a portion of the temporalis muscle is removed by this technique, so that the scarring and the fibrosis which is induced by the surgery will restrict the mouth opening. And lateral pterygoid myotomy is in which the attachment of the lateral pterygoid to the condyle and the capsule is cut down, and then a silastic block is placed in anterior to that of the surface of the condyle. This results in restriction of the mouth opening only for a short period of time. Next is eminectomy. Eminectomy is basically you are removing the obstacle. So, eminectomy works by allowing free movement of the condyle over the eminence, so that the locking of the condyle is prevented, so that there will be a free movement of the condyle in and out of the glenoid fossa. The high condylectomy works in a similar way as eminectomy. You are removing the part of the 2 to 3 mm of the condyle, and then this also facilitates easy movement of the condyle along in and out of the glenoid fossa. And as a last resort, when all these surgical modalities or the conservative methods have failed, the last and the foremost resort is to do a temporomandibular joint reconstruction, which is the condyles usually are made up of cobalt chromium alloy, and the fossa of the component is made up of highly polymerized polyethylene, and then it is available as stock and custom made processes. This should be the last resort when all the modalities fail. Thus, I conclude by saying that temporomandibular joint dislocation, it is a painful condition that can significantly impact oral function and the quality of life. Prompt diagnosis and treatment are essential to prevent complications, and conservative management often resolves the issue, but recurrent cases may require surgical interventions to restore the joint stability and to ensure long-term relief. Thank you.